Welcome to Value-Based Care Insights, brought to you by Lumina Health Partners, an ECG management consultants company. We are a national healthcare consulting firm that is redefining healthcare together with our clients. In this program, we will explore the big trends in healthcare and have real conversations about how provider organizations can meet today's challenges, strengthen performance, and transform care delivery. Value-Based Care Insights is hosted by Daniel Marino, principal at ECG. For additional insights, visit ecgmc.com. Dan, over to you.
Welcome to Value-Based Care Insights. I am your host, Daniel Marino. On today's program, we're going to dive into physician compensation and not really talking about the models per se, but really talking around the growing challenges, the growing complexities that we're seeing in physician compensation, especially as organizations are continuing to grow and continuing to employ physicians and other providers. One of the things that we often hear, or that I often hear when I talk to physicians and even with CFOs, is incentives, the goals aren't necessarily aligned. And I've always believed that form follows function. You need to have a good structure in place, and then we need to have the right level of incentives that create the right level of behaviors that align performance around all of our goals. If all of those things align, then you've got people who are happy, you're able to hit your financial targets, and the organization and the individual can prosper. Easier said than done, though. In a lot of the compensation models, they have become very complex. In some cases, a lot of them are very RVU, productivity focused. We're starting to see elements of compensation that are driving efficiency and reducing costs. We're seeing components in there that maybe are more and more aligned with value-based care, and especially as organizations assume some level of risk, those elements have to be built into the compensation model. And not only is the compensation model becoming more complex, how we manage that compensation, the physicians ensure mutually aligned success is something that I think many organizations are struggling with, and frankly, I believe are under-resourcing within these large hospitals and with these health systems. So I'm really excited today to have two experts in the field, two great guys that have been working in this space for quite some time. John Morris is a colleague of mine who has tremendous amount of experience working with large physician enterprises. He has 15 years of experience helping organizations design high-performing, incentive-driven incentive models, and has done a great job of putting these compensation structures in place. And my second guest is Alex Krouse. Alex is an associate general counsel of a large health system in the Midwest. He's focused on aligning a lot of the legal strategies with the financial and the performance components, tying that into compensation for physicians. He is also the board chair of the AAPCP, which is an organization that provides support to physicians around and to leaders around compensation. Alex, John, welcome to the program.
Thanks for having us.
So, John, maybe we could start with you. Given your experience working with physician enterprises, seeing, being part of a system that has really experienced a lot of growth, bringing on new physicians, what have been a couple of the challenges that you've seen around the growth of compensation and really alignment around the compensation models with the goals of the organization?
Well, I feel like I've seen a lot of organizations at this point, 10 years in consulting, 5 years on the leadership side for a large Catholic health system, and then coming back to consulting now. I have a slightly different perspective, approaching these problems, having, been on both the side of advising people on how to deal with the problems and then actually dealing with them myself. So it's, I would say that I'm trying to, in my approach to things and as I advise clients through issues, really strip things back to, why are organizations functioning this way? And the more I look at it, I think about how physician employment has developed over time.
Right. Well,
You know,
it has. I mean, it's changed. I mean, it used to be straight salary. Then
yeah,
it's gone into building these employment models around RVU based, strictly productivity. And now you're seeing a lot of value-based care influences where quality is
yeah,
being tied in, efficiency, cost reduction, all of these things, creating quite the complex structure of compensation.
sure. And the organizations have gotten more complex too. And I think that's
Yeah.
one of the biggest issues
Yeah.
that people overlook is, you know, 20 years ago, fewer than 50% of physicians were employed, and now we have over 80%,
Right.
employed. So the scale of these issues have gotten much larger, where
Absolutely.
you could be
Absolutely.
managing these things in Excel workbooks with a small team, and it wasn't that big of a deal at that scale. But now, where you have health systems that have kind of continuously merged and acquired other systems and gotten bigger and bigger, and have a larger, group of employed physicians, the complexities just kind of multiply
Yeah.
scale, and so
Gotten
do the
more
headaches.
It's gotten more challenging.
Right.
Absolutely. Alice, let me turn to you for a second. Working with a large health system and speaking with your colleagues, I think one of the things that I've seen and I think you've begun to work through this is I think the health systems are under-resourced and they have really a lack of structure to really not only build the right level of compensation and aligning the goals with the compensation model, but making sure that the ongoing administrative support is there to allow for that success over time.
Yeah. Yeah. Well, and I think to your point, I mean, from an organizational standpoint, the biggest mistake I think health systems make is treating provider compensation as a compensation problem. Now, I know that sounds kind of odd, but provider compensation is actually just a phrase that represents what I view as enterprise governance,
Mhm.
operations, financial, and workforce strategy all in one bundle. And so the organizations, quite frankly, that are managing this best are ones that are building mature infrastructures rather than just simply, kind of tweaking the compensation
Sure.
formula
Mhm.
every year. And part of that is, and we can get into this, part of that is complexity of models. And
Hmm.
part of it is the infrastructure to support that complexity and that
Right.
strategy.
Yeah.
So those are kind of the two pieces that I view this as.
So when you think about the infrastructure that goes into not only building the compensation model, but also then administering it and making sure that it's successful ongoing, right? Because things change and the compensation model should evolve with the changing environment. I sort of think you've got to have a strong financial team to do the financial modeling, right? You've got to have the legal support there to make sure that it's reflecting the model is legally reflecting what has been discussed from a business and from a structure standpoint. What are some of the other elements though from an infrastructure standpoint that you're seeing that maybe organizations are missing or that should take into consideration as they're really driving these models?
Yeah, yeah. Well, and I'd like to hear John's thoughts on this as well, because I know, he spent a lot of time working on this. I mean, I think big picture, an integrated provider compensation, and maybe we're narrowing it a little bit, but a provider compensation and workforce strategy department,
Hmm.
it needs to exist within organizations. Now, certainly it can't be, we can't lose sight of big versus small organization,
Right.
markets, this and that. But I think one of the historical problems we've had in this space is, well, finance does this,
Yeah.
operations does this, legal makes sure we're following the Stark Law,
Yeah.
and then
Yeah. Everybody has their silo in their bucket, right?
yeah, let's talk about that. But what we're talking about today from an infrastructure standpoint really sits at the intersection of all of that.
Yeah.
And so organizations need to rethink their workforce through this lens. And I don't know, I mean, John, I know we've talked about this a lot.
That's 100%, where my mind is at too. It's people always think of it as just provider compensation, but that's really just the tip of the iceberg. And these organizations have usually a bundle of people in the back office, kind of filling in the gaps in between all the different departmental silos. And
So
the
why don't Let me ask you a quick question here, John.
You
Why don't you think organizations have moved forward with creating
know,
more of an integrated model? Is it
you know,
because this is the way they've always done it? I mean, is
yeah.
it really that big of a paradigm shift?
Well, I think it's a few things. One, I don't think there's any shortage of crises to manage in healthcare right now.
Well, that is
So
true.
I can understand if you're, a CEO or a president of or someone in operations managing and responsible for, the ultimate bottom line performance of an organization, that you're not immediately thinking about, man, I really got to get my team doing better than managing this work in spreadsheets or something. It's not the top of mind thing, but that it's, I think, surprising how impactful, that piece of the business really is to performance. And that's where I'm trying to actually draw real, numbers to that. If you have a certain percentage of your physicians who are actually leaving the organization early and your attrition's higher because it's cumbersome to work there. They're not getting clear or transparent communication about their pay, or they don't understand how they're paid, or just processing everyday things about their employment is difficult. You might think that that's an HR issue, but a lot of the times, some of those problems that they experience or frustrations that they're having in the organization are coming from provider employment issues, and it could cause them to sometimes want to leave early. And every single physician who leaves an organization has a major
Oh, yeah.
cost impact to the bottom line, and that's
Yeah.
something that you know I think few organizations really track enough and do something about. The second reason I think is just that this space is pretty new. Like when you think about how new work RVUs are in the context of history, and how that's really sort of propelled the beginning of this industry as a whole. Like, why do we have physician compensation experts? A lot of it has to do with it's because it's more complex than managing salaries, right? But
Right. Well, and
there's,
it tracks to some level of performance, which at the end of
yeah,
the day, most of our hospitals and health systems, I mean, they started out and many still are very fee for service driven. So
absolutely.
you
And I
kind of
think
see
the other
it.
thing is it's a little young, and there haven't yet been major milestones made in bringing it all together the right way. Like out of all the organizations I've advised or worked in healthcare, I don't think anybody has it fully figured out. There's some who are definitely further along than others, and on the level of maturity and managing that work, but I don't think anybody has it figured out yet. I don't think that like there's really anyone who's like, yep, this is the gold standard. Everything should look like this,
Well, and if they figured it out today, it changes
Yeah,
tomorrow, and then
right.
they're reinventing themselves.
And one thing quick that I wanted to mention with this is, number one, we are seeing the evolution of this.
Mhm.
So, just do a quick job search for physician compensation or provider compensation, and you're going to see anywhere from SVP, VP roles to analyst roles. So systems are doing this, and the
Yeah.
biggest organizations in the country are doing this. But you got to think about it this way, and maybe an analogy is good. If you think about cybersecurity in large corporations, a decade ago, different departments handled different pieces of that. You had IT managing the software systems, legal handling breaches,
Sure. Right.
HR managed the training related to it. Now you have chief information security officers
You're right.
because it
You're right.
doesn't
You're
make
right. It's all
sense.
brought together. Yeah.
Correct. And
Right.
so I think now we are seeing a recognition of, hey, you really shouldn't have payroll over here, the strategy and design over here, the compliance aspects, this, let's bring it all together. And that department is going to partner with your physician leaders, your operational leaders to really advance the strategy of the organization
Well,
in a I think a very different way than it historically has been.
absolutely. And I tell you, that makes so much sense because physicians drive the clinical activity within hospitals and health systems. They are the connector between what patients need
Mhm.
and driving that level of performance. And I think to providing that level of support, absolutely key. I mean, it just makes perfect sense. If you're just tuning in, I'm Daniel Marino. You're listening to Value-Based Care Insights. I am here with John Morris, an industry expert, an advisor, working with many organizations across the country on physician compensation models. I'm also here with Alex Krouse, Associate General Counsel of a large health system in the Midwest. So I want to dive into one element that I think is important. when you're thinking about compensation models, there's some elements of that that have to be standardized. There's some elements that can be customized, right? How
Yeah.
does the structure that we're talking about support that in such a way that you're creating an incentive-based model that's really fulfilling not only the goals of the organization, but really what the goals are and the aspirations of the physician? Alex, let's start with you.
Well, so I mean, I think one issue is historically organizations have built comp models for a world that really no longer exists, meaning the pure production era was where most physicians care was, episodic, procedural, fee for service. Team-based care wasn't nearly as mature as it is today. APPs 10 years ago, people didn't even, recognize the term APP.
Sure.
So when
Yeah.
John mentions new, work RVUs aren't just new. The entire paradigm of where we are working within really is new. I mean, it's brand
Yeah.
new. So physicians are being asked to do more, lead teams, work alongside with APPs, improve quality metrics, access. I mean, I just threw out four things where work
Yeah.
RVU wasn't one of them, and that's
Yeah.
complex to manage.
I mean,
It absolutely is. And John, so when you've looked at this, how have you solved for both of those issues, right? The standardization versus customization.
that's a constant battle. And I mean, we sometimes get engaged where people want to build like a new cutting edge model, right? And then
Yeah.
you look at, okay, well, how much of your payer mix is tied to value-based care?
Yeah.
Uh, well,
Right.
it's still 90+% fee for service, right? Does it really make sense to put in a new cutting edge model then?
Or
Or
conversely, I was working
right.
with one organization. They had
Mhm.
30% of their revenue tied to value-based care and risk-based models, yet their employee compensation model, 95% RVU based.
Yeah.
And what they were seeing was they were failing on the
Mhm.
value-based contract performance because of overutilization. And it is that
Yep.
chair, right?
It is. And it's really hard to strike the right balance, but I always start there. Let's think
Yeah.
about how you're making money right now. Think about what your goals are and how you want to, what kind of patient experience you want to provide and what, you know, um, your strategy is long term versus short term. And let's build a model that supports that idea. And then,
Yeah.
second, how are you running your model? What kind of
Yeah.
team do you have to run it? Because if you build something that's too complex to actually administer, that doesn't help anybody. It makes
Right.
things a lot worse. So, especially when you have post M&A or post transaction type situations where you're coming in and redesigning a compensation program and or merging two together, that's a really important time to really take a step back and say, is structural simplicity actually even more important than
Oh,
uh,
it is. Agreed.
incentivizing all these things? And in my opinion, the answer to that question is leaning yes more often than not, because if you're trying to administer a model that's too complex and you have a team that's too small to support it, you're always just going to be dealing with turnover issues in your own organization and trying to keep it running.
Alex, how much in these compensation models that you're seeing, how much is the physician shortage coming into play? How is it influencing the models? One organization that I was working through, they of course are going out and they're recruiting primary care physicians, and of course they're competing with every other health system in the country for the same primary group of primary care physicians. And their solution was, well, let's just build the incentives into the compensation model so, we get these primary care physicians looking our way. How much has that influenced the model, or should it influence the model?
Well, I mean, I think you have, I mean, we've had the physician shortage as a general concept has existed,
Yeah.
forever.
Right.
We've not been in the non-shortage, space. Now, I think organizations, I think one question is there's obviously without a doubt a question of you need to get physicians in the door.
Yeah.
You need to bring them into the organization. But I also think there is not enough focus, and I do think this is where comp models are important, in stability. Most
Yeah.
individuals want stability in their work, stability in those incentives, predictability. So I think one mechanism is, as opposed to variability and complexity in models, you really need to have models that are built more around stability. So I'll give you just some specific examples. You're going to see higher base salaries, not pure work RVU models, so that offers a stable base, but
Yep.
you're also going to see models where you don't have 10 different metrics in the bonus
Mhm.
structure, because if you're incentivizing everything, you're incentivizing nothing.
Yeah.
And you're also focused on, I think, and some do it through physician compensation committees, but some do it just through, just having an open door of, let's talk with the physicians, let's talk with the advanced practice providers, not about how much we're paying, but what is working within these models. And I think when we talk about shortage of physicians, you're going to have physicians gravitate towards that type of environment when you've kind of built transparency and stability within your models.
So John, have you seen that? Is that what you're seeing within when you're working with the health system? Is the stability factor, is
You
it
know,
is it becoming even more important?
what Alex is talking about here is very true. And what I would say is that I see it most prominently when I'm looking at generational differences between physicians.
Yeah.
The new generation of physicians, and obviously that's also relevant and important when we talk about physician shortages, because the youngest generation of physicians is coming in to replace the
Yeah.
generation that's leaving the workforce, and that is leaving a big gap. And to Alex's point, I see a lot of them more interested in stability. And I think there's a lot of good reasons for it. I mean, they have a lot of student debt. They have, increased housing prices, all sorts of other things that they just want to make
Oh,
sure, am I going to be
yeah.
able to afford a life based on this? And what does that
Well,
look like?
and a
Some
lot of the
consistent.
younger generations of physicians, I mean,
Mhm.
they're interested in work-life balance, right? And that's
Yeah, that
all.
too. Call pay has been
Big-
an issue on that front. And getting call coverage, because you know
Yeah.
the physicians who have been in the workforce for a longer time will tell you that there is no work-life balance when you're on call. And the best you can do is try to get that panel up to a large enough number that you can kind of split the burden,
Yeah.
in a way
Absolutely.
that's a little better. But I think that's a good point.
So, Alex, I want to give you a chance to talk about the AAPCP. You've done a lot of work, you and John, on kind of
Yep.
developing this as a resource structure. Talk a little bit about what it does and some of the focuses and the support that you're providing to other healthcare leaders.
Yeah, absolutely. So the AAPCP is the American Association of Provider Compensation Professionals. You can find us at providercompensation.org. We are the leading national association focused exclusively on provider compensation and workforce strategy across healthcare. So our members, 225 healthcare organizations, large private practices, large health systems, alongside members from many of the leading consulting and valuation firms in the country. We have not been around long, but as kind of John mentioned before, a lot of this is coming together
Sure.
more recently. What we do is we offer a space for these professionals. We have a national conference each year in Nashville. We also have created the first credential worldwide in provider compensation valuation, which
Hmm.
is not just simply picking a number in a certain survey, but really is a holistic review of that arrangement. So for anyone interested in getting involved, there's several ways to, engage. Organizations become members and attend the conference and can participate. And individuals working in this space get the credential and education. And yeah.
I commend you and John for being a part of this organization and creating that level of resourcing, because I think, as we've talked about here, it's undersupported. It's something that is really needed. And I think if we're going to continue to drive strong partnerships with our physicians, we have to think about a different type of a model, different type of support structure to align around everything we've talked about. Well, gentlemen, thank you so much for joining today. Just real quick, I'll go to each one of you. If any of our listeners today are interested in getting in touch with you, how can they do it? Your LinkedIn address, or share your email or something in that regard? John?
Yeah, so I mean, you can find me on LinkedIn, John Morris at ECG Management Consulting, and I'm pretty active on there. Happy to connect to anybody who wants to talk.
Wonderful. Alex?
Yeah, I'd say the same thing. Find me on LinkedIn, Alex Krouse. Send me a message, connect with me, follow me. Happy to help.
Wonderful. Well, thank you, gentlemen, for joining us today. Great discussion, and I think we've only scratched the top of the iceberg. So thank you again. I really appreciate it. And a special thank you to all of our listeners for tuning in. Until our next insight, I'm Daniel Marino, bringing you 30 minutes of value to your day. Take care.
Thank you for being with us today. If you're navigating the shift to value-based care or looking to enhance the performance of your organization, we're here to help you move forward with insight and impact. Visit ecgmc.com to connect with Dan Marino and explore our advisory services. While you're there, check out our latest insights and thought leadership, follow us on LinkedIn, and join the conversation using hashtag VBC Insights. We're Lumina Health Partners, an ECG company. Until our next VBC Insight, keep leading the change.